All right, good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today's topic is on neuroendocrine tumors and some of the practical considerations for those of us in the palliative and hospice care world. We are honored to be joined today by Dr. Heidi Del Rivero, who started her medical career at the University of Veracruz in Mexico and holds fellowships in both endocrinology and in medical oncology with a research focus on endocrine malignancies. Dr. Del Rivero is a physician scientist in the developmental therapeutics branch at the National Cancer Institute, National Institutes of Health, and her current efforts are in the development of novel treatment approaches and targeted therapies for endocrine malignancies such as advanced gastroenteropancreatic neuroendocrine tumors, adrenocortical cancer, and pheochromocytoma paraganglioma. Heidi, welcome.
Great. Thank you. Thank you so much for having me here and for the introduction. It's really a pleasure to be here and talking with you all. To me, this is a very important for any cancer care, of course, but for the type of tumors that I see, I think that getting involved palliative care earlier is just improved quality of life in our patients. So thank you.
Absolutely. Our pleasure. So, our format today will be sort of a brief interview discussion, and then we'll open it up for some questions from the audience at the end if we have any. So, we start off with your paper, Heidi. You touched on the frustration and the discouragement and the difficult journey of this population. Could you tell us a little bit about what you've seen and how we can maybe be more empathic to this population's struggles?
Yes, no, great. Thank you so much. And just a little bit of the background of how this paper was developed. We have one of patient advocacy. We work very closely as a field that there is so much to learn and there is so much in terms of improved quality of life. We work very closely with our patient advocates. And there is one patient advocate, his name is Josh Melman, who is a neuroendocrine tumor patient himself, was discussing when they have discussions with the patients as well. And even when I was seeing my patients and I was discussing like end of life situations, we felt that even in the few months of life, these patients were suffering. And one of the things is because of the hormone excess related to the neuroendocrine tumors. So as we know, neuroendocrine tumors can be anywhere in the body, and they're characterized because there are specific markers that makes a neuroendocrine tumor a NET. But at the same time, another aspects of these tumors is that they can produce excess of hormones. And these excess hormones can produce very specific symptoms and syndromes related to these excess of hormones. And even in the time of hospice and hospice care, we felt that these patients were not getting some of the basic needs in terms to keep the patients comfortable. And one is managing the hormone excess. And we wanted to educate, our physicians and physicians treating neuroendocrine tumors, not only to involve palliative care earlier in their diagnosis of the disease to improve quality of life, but at the same time in their hospice time to be able to help come with some important points to help manage their hormone excess. And depending on what neuroendocrine tumors are, there are different hormones and different symptoms related to that. But one of the most common neuroendocrine tumors is the neuroendocrine tumors of the GI tract that produce excess of serotonin. This excess of serotonin is translated into diarrhea, flushing as the most common. And we have our patients in hospice care that they have like 30 bouts of diarrheas when they don't get the somatostatin agonist. And because of that, we felt that we needed to educate, physicians about this situation.
Lovely. Yeah. So the typical non-endocrine cancer patient in our palliative care clinic is often quite advanced and maybe has quite a few symptoms and often a diminishing prognosis. And that prognostication, it's so important to us because we're trying to be mindful of symptom management and exposing patients to chronic opioids. But the endocrine malignancies, they can be both metastatic and yet have a sometimes a much better prognosis than some of these other non-endocrine cancers. Can you share a little bit of insight with us about your thoughts on prognostication for these tumors?
Yes, so neuroendocrine tumors, compared to other cancer types, they're relatively slow growing. And even in the metastatic setting, these patients can live with metastatic disease, significant volume of disease in the livers, and still they can live for a decade or so. And one of the reasons is because they are these neuroendocrine tumors, they're well differentiated. And just to kind of like because the nomenclature and the classifications can be sometimes quite complex, but now all neuroendocrine tumors and carcinomas is within the whole umbrella of neuroendocrine neoplasms. And then they're divided into neuroendocrine tumors. Neuroendocrine tumors are well differentiated. They're relatively slow growing. Patients can live for a long periods of time, where the neuroendocrine carcinomas, they're much more aggressive and they have a dismal prognosis. So there's kind of like two types of these, what we call neuroendocrine neoplasms, tumors and carcinomas. Treatments are completely different between the two of them. Usually neuroendocrine carcinomas are treated with chemotherapies and very aggressive dismal prognosis, not that many treatment options compared to other cancer types, whereas neuroendocrine tumors, we still have some treatment options, mainly just for stabilization of disease. Most of the treatment doesn't necessarily shrink tumors, but yes, because sometimes can see patients that, they have, a significant volume of disease, a performance status are like zero, and still patients are able to walk, work and exercise and do to day-to-day activities, what we compare to other cancer types. But that's basically the biology of these neuroendocrine tumors, and a lot has to be because of this slow growing nature of the tumors.
Some of the really well differentiated tumors can go on for decades. Is it even realistic to expect that some of them may die with their cancer than from their cancer?
Yes, the most common cause of death in the patient of neuroendocrine tumors is usually liver failure, just because that's kind of like where the disease and mainly goes, and it can be quite extensive. But yes, I mean, if they have any other comorbidities, knowing that these patients can live for 10 years, I mean, we have patients that have died of other causes, but not necessarily of neuroendocrine tumors, again, depending on what other comorbidities they have, or sometimes we have patients that may have other cancer diagnosis not related to neuroendocrine tumors. And when that happens, that we have a breast cancer diagnosis, and then we have a neuroendocrine tumor diagnosis, we usually tell our patients, focus on your breast cancer diagnosis. There are more treatment options and they can prolong survival, but at the same time, based on prognosis, compared to the two cancer types, we usually tell our patients focus on the most aggressive cancer, not necessarily on the neuroendocrine tumors, because we know that these patients can't live for a long periods of time.
Lovely. All right. All right, so now the octreotide, lanreotide portion. So many different avenues here. I mean, I'd love to get a little bit of your thoughts on how this really works, how it helps with symptoms, how it's more than just for symptoms, how it can impact disease progression. Uh, the floor is yours.
Yes. So usually the first treatment of first line of treatment for neuroendocrine tumors, and as I discussed earlier, there's many different neuroendocrine tumors can be anywhere in the body. Depending on where the neuroendocrine tumor is located, they may have different symptomatology as well. And again, they can produce hormones, and that can also be associated with different syndromes as well. And as I mentioned, a lot of these tumors can produce hormones dependent, like up to 90% of patients with a small bowel neuroendocrine tumors that metastasize to the liver can produce serotonin. Up to 40% of patients with pancreas neuroendocrine tumors can produce hormones. The other more rare subset of neuroendocrine tumors are the pheochromocytomas and paragangliomas. Most of them, they can produce hormones, and there is a specific symptoms related to that hormone excess. And mainly for the GI and pancreas and lung neuroendocrine tumors, our first line of therapy is the use of somatostatin agonists. So there are two of them. One is called octreotide, long-acting octreotide. Another name is sandostatin, or we have lanreotide or somatoline, that's the other name. The first one that was approved was the octreotide, the long-acting octreotide. And when they did this study, that was mainly for mid-gut neuroendocrine tumors, or functional neuroendocrine tumors. The primary endpoint was exactly symptom control, but they also saw that they have a benefit in progression-free survival and stabilize the tumor. So that's kind of like where, the other endpoint was explored, and they also saw stabilization of disease. Now, lanreotide came a little bit later, and based on what we have learned from the octreotide, lanreotide came a little bit later, and that primary endpoint was progression-free survival, and of course, secondary endpoint was also symptom control. But the way when I see my patients, I usually tell my patients that we use this type of drugs for two reasons. One is to control tumor growth. It doesn't make the tumor goes away. It doesn't shrink tumors. It's just slow down disease progression. It's kind of like what we call cytostatic activity, but also it can help in hormone excess. And hormone excess symptoms, like for example, if a patient has a serotonin syndrome or carcinoid syndrome related to not serotonin, carcinoid syndrome, because that's a different thing. But when the patient develop a carcinoid syndrome related to the excess of serotonin, that has a significant symptoms related to diarrhea, flushing, and that can, by giving that medication, can certainly control a lot of the symptoms, and it's life-changing to the patients, because when that happened, it's very debilitating. Just to have like 20 episodes of diarrhea a day, patients doesn't even want to go out of their home, because they always need to look where the closest bathroom is. But that medication certainly improved their quality of life by controlling the symptoms related to hormone excess. And that happened also with a lot of the other neuroendocrine tumors that produce hormone excess as well.
So I imagine that as the disease progresses,
Mhm.
it eventually reaches a point where that octreotide maybe is no longer helping to slow it down, but it is still being efficacious in a way to help with symptom management and comfort.
Absolutely. And that's kind of like, because I mentioned we have still these non-functional
Yeah.
neuroendocrine tumors that don't produce hormone excess. At the point when there is disease progression, then we discontinue lanreotide or octreotide, because we know that it's no longer efficacious. But in a patient that have a neuroendocrine tumor, a functional neuroendocrine tumors, we always keep them. Even if the tumors grow, we always keep them, because we know that this helps also to control the symptoms related to hormone excess.
Yeah. And that kind of answers my next question, which is when would you advise somebody to stop it? But in a functional tumor, indefinitely,
Always.
as long as you can. Sure. All right. Um, so malignant PHOs are rare. And I've had a total of one case in the last decade of my clinical practice. And it's actually that case I was telling Heidi that led me down this rabbit hole to find her paper. And I read in both the Endocrine Society clinical practice guidelines and in a case report from 2023 in the Journal of Palliative Medicine that some symptom management medications commonly used in palliative care or hospice, certain opioids, some antiemetics, some steroids, some TCAs, may have the potential to trigger a life-threatening catecholamine crisis in pheochromocytoma. Now, it was based on anecdotal evidence and case reports. You sort of live in this world. Is this something that you've seen? Do you think these concerns are real? Are they more hypothetical? What's your advice on this?
Yes, I always love this question, because this is a constant question that I get from a lot of providers as
Mm,
well.
mm,
Um, so when the patient with a PHO has been recently diagnosed, most of the time they produce hormone excess. So like similarly to the GI and pancreas neuroendocrine tumor that I talk about, pheochromocytomas and paragangliomas, another rare subset of neuroendocrine tumors that it can also be anywhere in the body. It could be in the adrenal gland, they're called pheochromocytoma, or it could be anywhere in the paraganglia chains outside of the adrenal gland, those are called paragangliomas. Paragangliomas can arise either from the sympathetic nervous system or parasympathetic nervous system. Parasympathetic is located anywhere on the chest, I'm sorry, on the head and neck. Usually they're biochemically silenced. They don't produce hormone. Less than 5% can produce hormones. But any paraganglioma of the chest, abdomen, and pelvis that arise from the sympathetic nervous system, then can produce hormones. So there are certain medications that if the patient is not aware that have a pheochromocytoma, they can cause catecholamine release, and because of that, they can produce hypertensive crisis. That's kind of like sometimes these patients are diagnosed, like for example, they have a procedure that they require anesthesia, colonoscopy, and the procedure, and then they see that their blood pressure goes very sky high, and then it's like that's kind of like when they start thinking like, could this be a pheochromocytoma? There are certain other medications, even steroids, that can cause a release of catecholamines and can certainly cause hypertensive crisis. But in the setting on hospice and palliative care, those patients are often metastatic, and those patients are and having a significant amount of catecholamines. But we have medications in order to prevent or some of the complications related to catecholamine excess. And depending on what, and another thing about this type of tumors, it also related to the amount of hormones that they produce. Sometimes these tumors can produce catecholamines, methanephrin on the 20,000, 80,000, and that can have fluctuations on the blood pressure. It could go very high, it could go very low, because it can also, the receptors, they kind of like bind to these alpha receptors and beta receptors. Usually what this hormone do is that it binds to the alpha receptors located in the vasculature, and when that happens, it can cause vasoconstriction, increase of blood pressure, but they sometimes they get overly saturated when there is so much hormones, it can cause vasodilation and it can go very low. So, but there are hormones that can certainly, medications, or that can certainly help manage those not only fluctuations on the blood pressure, but also as well some of the catecholamine excess too. And as long as the patient is well blocked, there's really no concern. I mean, my opinion, given these medications that can certainly improve quality of life, especially in the more on the terminal settings. And that's one thing that I also mentioned in our paper, is that these patients need to have medications not only to manage the blood pressure, but there is another medication that blocks the rate-limited enzyme that produces these catecholamines. Sometimes that may be needed in order to help manage the symptoms related to hormone excess, but in the hospice care, whenever they need controlled pain, with morphine, for example, Dilaudid, is not as a concern, and the patient needed. When the patient needs these medications, they need it. Even, for example, in patients that are receiving chemotherapy, there is a chemotherapy regimen, IV chemotherapy regimen, where prednisone is part of the regimen, antiemetic regimen, and this is something that we just give it as long as the patient has the medication needed in order to control some of this hormone excess. One thing, because I think that's one of the questions that you asked, was about morphine and kind of like excess. So usually whenever you give these types of opiates in the acute setting, it actually lower the hormones. It's more on the chronic setting, when the patient goes into withdrawal, that's kind of like where, we see a rebound, and there is a release of these hormones. But in the acute settings, it's actually lowers these hormones, and that has been also been proven as well. But that said, I think one thing that we need to know and learn is that in patients with metastatic disease or advanced disease, localized advanced disease, as long as they have the adequate medication to block these alpha receptors to improve the symptoms, other medications are thought to be causing some type of hypertensive crisis, is less of a concern. And that's kind of go with any procedures, like as well if the patient, the other thing that question that I was getting is like, oh, the patient can have a CT scans because the IV construct can cause hypertensive crisis, and that has been proven to be a reason. Sometimes it is with procedure, sometimes a biopsy. Physicians are scared to do a biopsy because it can cause hypertensive crisis, but as long as the patient are very well blocked, it's less of a concern.
Okay. But I'm going to summarize it back to you since this is so complicated. Make sure I've got this right. So, yes, the theoretical risk is real, but in that world of that hospice and palliative care patient where the symptom management really is paramount, as long as you are have access to alpha blockers and making sure you can counteract that, it's okay. You've got a way around some of these things. Don't feel paralyzed to not be treating symptoms.
Right,
Yeah.
exactly. Symptoms important in these neuroendocrine tumors. Symptoms are very, very important to treat.
Okay.
Besides their metastatic disease or their advanced disease, symptoms is important.
All right. One last question before we open it up to the audience to see if they have anything. So, what features of neuroendocrine tumors do you see that are most often overlooked or misunderstood or mismanaged so that you can give our palliative care audience something to come away with a better understanding?
Yeah. Yes, one is, and thank you for that question, because I do feel that neuroendocrine tumors being a rare cancer, even though the incidence of neuroendocrine tumor has increased over the last 2 decades or so. And then if you ask me why we see an incidence increase in incidence of neuroendocrine tumors, one of the reasons is because, they we are doing more diagnostic procedures, better diagnostic scans and colonoscopies, endoscopies, that sometimes we have increase the incidence of neuroendocrine tumors. But still, despite that, I think most physicians don't think about, these tumor types because they're so rare. If a patient comes to the office and say like, oh, I'm having this diarrhea, I'm having this flushing. So this is something that physicians may say, well, you have an irritable bowel syndrome, oh, you're premenopause or menopause. They don't really think about doing more workup after the diagnosis, before diagnosis of neuroendocrine tumors. And often these patients, whenever they are diagnosed, they're already metastatic. The same with paraphio. We call paraphio the greater mimicker because they never think about when a patient has a paraphio, and often every time I see a patient with paraphio is because it has symptoms for years, but they never think it's paraphio because it's rare. They don't think about the paraphio being a condition. When a patient has this headaches and they have this sweating, especially in a female patient, they always say, oh, it's perimenopausal, oh, it's depression, you need to see a psychiatrist. That's kind of like often. And also because of the symptoms related to this excess of catecholamines, they feel anxious, they start sweating, they have these headaches, blood pressure is high, but then it's like if somebody that is more in the 60s and 70s, they think it's essential hypertension. It's kind of like it's always misdiagnosed because again, one of the reasons is because of the rarity that when they see a primary care physician, they never think that this could be the reason why they have the symptoms. And I think one aspect is I feel like we need to educate our physicians more about that. If their symptoms happen, maybe we need to overlook more about what psychiatry issues are, because that's kind of like usually what these physicians think is always psychiatry, it's always anxiety, it's always depression or irritable bowel syndrome. So I think that will be something that needs to be discussed as well. And that goes also with another condition called Cushing's syndrome. These tumors can also produce excess of ACTH, and ACTH can stimulate the adrenal gland to produce excess cortisol. I mean, these even patients with Cushing's, because of the excess cortisol, they can also present with psychotic behavior, but they kind of like don't think much about that. And that's kind of like what I feel early diagnosis will be important, so that way we don't see these patients that are already, when we finally diagnose neuroendocrine tumors, often is in the metastatic state. Now, the other aspect I feel where our palliative colleagues can be very helpful is that also educating our medical oncologists that and patients as well that early palliative care consultation is very helpful because they can have a bit, and that has been proven in studies that if we involve palliative cares earlier in the disease course, they improve survival. But that also happened with patients even they live for a decade or so. I think that's one of the misunderstanding too, because whenever I see my patients with neuroendocrine tumors and we tell them, well, this is slow growing, you'll be okay for the next 5 years, 6 years, 7 years, 10 years. And then we say like, well, let's discuss with our palliative care group. They're always very afraid because they always feel that this says, oh, this is the end of life. Like this is one thing that I also feel we need to do a better job, including me, to educate our patients with a diagnosis of neuroendocrine tumor to be, so to see them earlier enough to improve quality of life. And the other aspect is about like the reason why we wrote this paper is on the hospice care, where important to recognize these symptoms. And as we know, and I think I was discussing with you earlier, Mark, the definition of hospice care is when a patient has a terminal diagnosis where the prognosis is less than 6 months or less. And when that happens and a palliative care physician makes that decision, there is minimal intervention that is needed because even given SSA is considered an intervention, when I say SSA, somatostatin agonist, is considered an intervention and is usually not necessarily approved and by insurance to get it. And then we have patients that are, and I have seen my patients. So whenever I see patients that, are in their hospice, we decided I need to go to hospice. I have gone and see them. I feel as a physician, I need to, especially because they has been with me for some time, and I can see their families are very frustrated that they say, I cannot get somatostatin agonist. I have to clean my wife like 20, 30 times a day. She's suffering. What we can do to do that. And they cannot get these injections. And the same with patients that have hypertensive crisis, because even to control the blood pressure, they consider that an intervention. And I'm like, we need to give that. That's kind of like one of the things that we were hoping that with this paper, we can educate physicians and even companies as well, in order to let them understand that these neuroendocrine tumors is just a different subset of neuroendocrine tumors that provide an extra care even in 6 months or less of life, to also give them quality of life. And I think hospice care, whenever a patient is a hospice care, is not for them to let them suffer, it's to make them comfortable. And part of controlling the hormone is to make them comfortable as well by controlling the hormones.
That feels like that's the take-home point, really, of this message is really you are advocating for if there is any way possible for hospices to continue these from a symptom management standpoint. So much of oncology hits some of those things. I mean, you think about some of the heme malignancies and people who are dependent on blood transfusions. That can be a barrier to hospice. Cost. I think same thing here with some of these octreotide agents, but it's a challenge.
Challenge. I completely agree. But one thing is that this hormone excess can be quite debilitating,
Yeah.
not only and symptoms not only for a patient itself but also for the family and the care, I mean, and caregivers is very difficult for them, because I have seen it when I have gone and see my patients, and having like a home visit. Families struggle a lot, and because it's kind of like they feel like they're not doing enough to make them comfortable. And even I remember one time I tried to talk to the person who was kind of like seeing the patient in a hospice setting, and she was telling me the whole situation. And it's not something, sometimes it's not nothing you can do, right? It's just how the health system is. So
Mm. Mm. All right. We are just about at time. Maybe I could sneak in one more question with you before we send you on your way.
yeah.
Um, so uh, not all of us work in a big health care system where we've got oncologists that focus on endocrine malignancies, right? Some of us are out in a rural area where just due to scarcity, you have one oncologist that is a jack of all trades. Is there a big difference between seeing somebody like you and seeing an oncologist who does it all for neuroendocrine tumors?
That's a very good question. Very good question. And just to let you know, because of that, we through American Cancer ASCO, American Association of Clinical Oncologists, we wrote two guidelines. One is about systemic management of neuroendocrine tumors, and we're about to publish symptomatic management of neuroendocrine tumors. And it's exactly to provide some guidance and patients with neuroendocrine tumors, not only from their cancer diagnosis and tumor growth progression, but also from the hormone excess itself. And we're trying to provide some guidance as well on how we can also manage some of these symptoms. But yes, we see a difference. And one of the reasons is because these are not very common cancers. It's not like the regular, prostate cancer, breast cancer, colon cancer that they see on a day-to-day basis, especially in medical oncologists in the community.
Sure.
Even though I feel like even this more common cancer has a lot different, so many options to choose from. But this sometimes, like I said, neuroendocrine tumors are a little bit more difficult because not only the tumor control growth, but also because of the hormone excess. And sometimes, kind of like educating medical oncologists in the community of what the options may be. So we see a lot of misunderstanding and what the management will be. And sometimes I have seen patients send to me, I do clinical trials that they send them to me because of, for a phase 1 study or other studies when they have not even exhaust all the standard of care options, because sometimes it's not something that they think about. And it's kind of like telling the medical oncologists in the community, I'm very grateful that you're sending me a study for this clinical study, but I feel there's other options that we could try before sending this patient on the phase 1 study, for example. So, and that's kind of like where, trying to educate the physicians in the community. There is also about symptom management as well. Number one, we discussed about the hormone excess and other complications related to the neuroendocrine tumors as well, like peritoneal fibrosis, because of this as the hormones can cause scar tissue. So that can sometimes cause obstruction. So it's kind of like educating physicians about it. But one interesting factor about, we talk about the SSA and how they can control the hormone excess, but if the patient doesn't have excess of hormone, because it inhibits some of the gut hormones, it can cause diarrhea. So in the type of diarrhea that it can cause is more a malabsorptive diarrhea. So it's kind of like we need to give medication for that. And sometimes in physicians in the community, they start an SSA and they see that they have more diarrhea and they think it's because of disease progression, when it could be a side effect of the SSA, especially those when there is no excess of hormone. So we see this, it can cause diarrhea, malabsorptive diarrhea, because it inhibit hormones and inhibit a lot of the gut hormones. But if those gut hormones are not in excess, then it can cause the opposite effect, and it can cause diarrhea. So it's kind of like educating physicians about, not only the tumor control, but about the symptom management. It can be a little bit more complex too. But we hope that with the guidelines that some symptomatic management soon are going to be published. I was fortunate to be the co-chair of those guidelines, not only for the systematic management, but also for the symptom control. So we hope that I can also provide guidance if the patient has diarrhea that is not related to the neuroendocrine tumor, what other causes could that be, how we can treat it. If the patient has this excess of hormone, other type of hormones like the insulinoma causing severe hypoglycemia, what are the options that we have in those situations? So the gastrinoma causing excess of gastrins, and in patients, have excess of, acid in the stomach that can produce ulcers and diarrhea and so forth. So it's kind of like how to manage this excess of hormones, which may be different from patient to patient as well. Moreover, one other aspect or interesting aspect about these neuroendocrine tumors is that even in the metastatic setting, surgery can still be an option, because the idea is to be able to resect at least 75% of the tumor volume, because we know that in prior studies that can certainly help prolong survival by decreasing the tumor volume, as long as you're able to resect 75%. So it's kind of like another aspect. And by doing that, that can certainly control the symptoms related to hormone excess if the patient has a functional neuroendocrine tumor.
Palliative surgical resection. I love it.
Yeah.
All right, Heidi. Absolute pleasure having you with us today. Thank you.
Great. Thank you so much. Anytime, I appreciate. And if there's anything I can do, you're one of my favorite group of people. When you email me, I say yes
Oh,
immediately because you're kind of one of my favorite group of people. And I hope that we can continue collaborating and interacting in these neuroendocrine tumors.
lovely. All right, everybody. Have a wonderful Friday.
You too. Thank you. Bye.
Bye.